Hello, everyone, and welcome. It's Saturday, April 11. Dr. Walter Slubro here. I am broadcasting live from Ontario, Canada. I practice in Vaughan, Ontario, Canada, and I live in Aurora, Ontario, Canada, but I'm broadcasting live from my home. And today's show, it's a special show. I will be interviewing another corrective care chiropractor like myself. His name is Dr. Khalid Mankil. I'm going to cue him in a moment. And today it's about corrective care for disc bulges. So without further ado, I'm going to cue in Dr. Khalid Mankil right now. We're going to get right into it. Hold right there. Hey, Dr. Khalid.
Hey, Dr. Walter. Good morning. Good morning
to you. How you doing?
Fantastic, bud.
That's awesome.
Good over here. Yeah.
So why don't we tell you today we're going to talk about corrective care for disc bulges, and we have an awesome agenda that we're going to go over today. And why don't you first tell us, our audience, where you practice and the type of practice you have, and who do you help in your practice, and how long you've been a chiropractor for?
I've been in practice for about 28 years. I'm a family corrective care chiropractor that focuses in neurostructural correction. So with your topic today, it kind of fits in line to some of the work that we do with regarding structural problems and its impact on disc problems and disc injuries, and then how we help people in a very non-surgical way by applying a corrective care process.
Mm-hmm. Yeah, it's great. Awesome. Now, when it comes to disc injuries, how often do you see them in your office? Do you come with disc bulges or disc complaints?
Weekly.
Yeah,
it's a very common occurrence, right? It's very common. It affects, a large percentage of the population. Typically see more of them in the younger age categories versus the older age categories, possibly because of the degree of hydration of that disc material.
Yeah.
But the good part about this, Dr. Walter, is that 80 to 90% of them can recover very, very nicely with a process that is directed at sort of changing the underlying structure and coupling that with some specific at-home exercise work that people get involved in. My thing I've seen in the past is a lot of people get involved in structural exercise work a little bit too early because there's other problems in the structure with regard to segmental movement that has not been addressed. So they definitely find the exercise to be a lot more challenging to participate in because some of the movement dynamics of the spine have not been addressed. Some of the adhesions that have built up, the irritation in the joint function has already started. So I think this topic is very poignant to the population because we're well aware that 80% of the population gets affected by back pain. Now, not all back pain are disc injuries, but a lot of them are.
For sure. Absolutely. We'll get into talking about the getting into the structural care before functional care and all that stuff. But a lot of times sometimes people come into our office and they already come in with their MRI report, and they know they have the disc bulge, like an L405 disc bulge or an L5S1 disc bulge. And then sometimes they present to our office with a back pain complaint or a gluteal pain complaint or leg pain or numbing, tingling, and they don't know what the diagnosis is. So let's talk about some of the signs and symptoms of a lumbar disc bulge and herniation, especially for someone that and we're not diagnosing anyone on this show, okay, but this is just general information. But for someone that has not received an MRI report to confirm their diagnosis, what kind of signs and symptoms relate to disc bulges and disc herniations?
Well, just initially, the way that they may present something called antalgia, or they're bending away from the side of the bulge to get away from the pain and the swelling. So they kind of maybe are leaning to one side versus the other, depending on how the disc has been bulged. They'll typically will get back pain that goes into the hip, down the back of the leg, and even as far into the calf, and sometimes they'll get even a common numbness down the leg or into the toes. So those are the common things. Some of the extreme cases that are probably outside of this conversation are people that start to experience a loss of bowel control and bladder control, something known as cauda equina. Those are emergency type situations present to the hospital. But they're not the most common. The most common things are where the disc has been injured. There is some pressure and swelling now around that nerve. People present with the postural distortion, leg symptoms of pain and numbness and tingling, and movement disorders.
For sure, for sure. And it's a good thing to point out those red flags of back disorders, the saddle anesthesia, like you said, the bladder, a loss of bladder and bowel control, and as rare as they are, but it's good that people are aware of them for sure. Yeah. Now before we go into a bit more of the show, I just want to tell the audience, for all those that are watching, thanks for coming on. We are going to take live question and answers after the initial interview section, so stay on until the end, and make sure you plug that into the chat box during the live interview. And also let me know where you're from. Let us know where you're from, what city, what country, and where you're coming in from. We'd love to know where you're from as well. Okay, so say hello in the chat box. I won't be able to reply to the chat box on the fly because it happens pretty quick, but we'll try to respond to the questions in the video. So let's talk a bit about the anatomy of the spine and the disc. So how is the disc comprised? And I'll put some pictures up here as well. And why is it a problem when it's injured?
Well, there's two main central parts to the disc, right? We have something called the nucleus pulposus, and we have the annulus fibrosus, the annulus, and it's like I describe like a jelly donut, Dr. Walter.
Yeah,
you got the jelly in the middle that gives the degree of some stability to allow the nerves. Can I bring you to a model here, Walter?
Yeah, for sure.
Can I show that?
Yeah,
I think people
that's good. Yes.
I'm getting it right. There we go.
There you go. You got it.
Good there?
Yes.
Now, just to get the orientation. So there's our nerve in the yellow, and the disc material kind of acts a bit like a shock absorber, and it allows people to have movements from left to right side, and it's very dynamic and it's very fluid filled, and it's like cartilage material with a lot of watertight material in there. And so when people tend to have weakness within sort of stabilizing muscles deep into the spine, they can have poor mechanics, they can have a leg length inequality, they can have structural deviations of the spine that puts abnormal loads, if I can see that I can do this, and the load, what it does, if I can get this, there you go, perfect. So the load over time weakens bit more, and people tend to live on and off with this thing for a long time, thinking it's just a localized back issue. But as it hits the nerve, there's more swelling and more swelling and more swelling, and it becomes very, very chronic. So this is a good visual there, Walt. Hope your viewers can see there. Okay, does that make sense?
Definitely. It looks really, really good. Awesome. Yeah. And I want to put up another picture here so we get an aerial view of the disc and the nucleus pulposus and the annulus. Be back in a sec here. Right there.
Yeah, pictures help to really explain that.
So you see that right in the center. You see the annular fibers when they're strong and well contained. It's a super, super strong structure, right, Doc? Right? Oh. And then the inner material and nucleus is right there as well. And that's the spinal canal and the spinal cord and then the spinal nerves on the side. So what happens when there's an annular tear? What happens to the integrity of that disc?
Well, it loses integrity to contain the fluid within the disc, and that little jelly part shifts over to the side. And that cartilage type rings along the annulus, the outer fibers, they become injured, they become elongated, and then that it starts to create this swelling process along the nerve I was trying to show you there. Mm-hmm. Now, Walter, on my end, I can't see a picture. I'm not sure if your viewers can or not.
Yeah, there's one on the screen. It might come up later for you.
Okay, good.
But I have right now on the screen, on the split shot, the injured disc example with the annular fibers that are disrupted, and then the nucleus leaking out and beginning to form an early disc bulge. And then in the area below, people can see the disc bulge right there. Yeah, don't know why it's not showing up. I know there's a delay on the internet connection as well. Cool. Okay. Now I want to really get into the examination process. I'm not sure what it is from your experience in your office. So we're both chiropractors. We're corrective care chiropractors. And we'll talk more about that as we go along. and we're trained in a technique called chiropractic biophysics. And one of the things that I find, tell me if this is the same with you, is that sometimes people come into our office after they had months and months of problems with a disc injury. They've already been diagnosed, let's say 8 months ago or a year ago or 2 years ago or even longer. And all they have is a piece of paper, and and maybe they had some therapies and maybe they didn't. But before we get into the protocols, what kind of things would you assess in your office that might be a little different in other types of modalities or therapies? Like what things are you looking for specifically?
Well, the generalities obviously is the way they present with their posture.
Okay.
Do they have a deviation to one side or another? Not only from the front, Walter, but also from the side. So look, is the ear, knees over the ankle. So postural loading or abnormal postural loading are signs that this can be present. And then obviously the general gross range of motions. And many people cannot bend forward very well. Some people go backwards better and actually feels better, which is a good clinical indicator in extension. The side bending, depending on which way the bulge is, they may lose some of that movement as well. And some of the rotations, when they turn their bodies, they may have lost some of that. And then from there, the movement, then that's the gross ranges of motion. Then we can get into what we call the segmental motion. There's 24 vertebrae, 5 in the lumbar spine. Degrees of movement, but not a lot. And if Walter, if you could show that on your end as I'm talking there. So segmental motion, and then I'll use my hand to explain a couple of things. When we look at movement or segmental motion, I'll use my hand. Everyone has gross range of motion of a joint. I can raise my finger up and down, but then you can also, that's as far as you can go actively. But passively, we can go a little more if I push on it. And those things you could probably almost assess on your own. But the last part that we can't assess on yourself is something called joint play. And that joint play is something that is very unique to chiropractic in the sense of we're looking at the accessory joint play motion. That is something that determines the initial motion of active and passive range. So if we don't have the joint motion, it's hard to depict on the video, Walter. How do we assess that? But when someone doesn't have the accessory joint play, when you challenge it in a certain direction, it's actually very, very sensitive. Other areas in the range are not. So if someone in a rotation, they have normal motion, but if they do lateral flexion and they challenge them in lateral bending, it actually creates discomfort.
So rotation may be normal, but then when you're bending laterally, will cause a problem. It may be blocked, and the patient will feel that. So we want to get specific and to figure out which joint accessory motion is missing. And there's and they can be assessed in 6 different ranges at each level of the joint. So that's a huge predisposing factor to normal mechanics of the spine. So that would be the other factor that makes the chiropractic analysis maybe a bit more unique than other modalities and therapies out there. Very cool. Very cool. And we just got
you want to go ahead, Walter?
Yeah, I was just saying we have a delay with internet, so people just bear with us. Yeah, go on.
Okay.
This is good.
The other part that moves into is obviously we're going to look into also some reflexes. So reflexes is a spinal cord phenomena, and there are certain reflexes that many doctors look for to see whether you've lost the ability to have a normal reflex. And the other part could be looked at is muscle strength, because nerves supply muscles. And so we look at what we call something called the myotomes, where we can look at, is there any strength loss in certain muscles that are affected directly by those nerves in the lower back. So that typically happens around the foot area.
Very cool.
Okay.
So let's, I want to talk a bit more about alignment of the spine and also posture, because you talked about when there's bad posture and bad alignment, it alters the loads on the discs. So let's put that into perspective. Let me put a picture here about the disc loads, and then you can use that as we describe that. Hold on here. So because the disc is designed to take loads and weight, So when there, can you see the picture there, Doc?
I can, yes.
Okay, perfect. So why is it relevant to disc conditions when someone presents with a disc condition that we look at considering the loads in the discs? Why is it so relevant to look at that posture and alignment when we look at this picture?
Well, it's really loads over time. So if you look at, for example, the foundation of anything, there is a normal structural integrity with forces over time, kind of like the foundation of a building. If it drops on one side, there is now more forces going to be on ligaments, joints, muscles, and nerves over time. So loads over time create strain, and that strain leads to irritation, inflammation, loss of normal function.
Exactly. So a normal load, so here's a vertebra, disc, and then nerve. The normal load should be distributed axially, so from the top to the bottom, right? And it does have some give side to side, obviously, but when it's positioned in a long time in one direction, that's when we get problems. Is that right?
Yes.
Okay. Now, so go on.
I was just going to say a common thing that you'll see in somebody's history, even though they first felt this problem weeks ago, months ago, when you investigate their history, they were involved in either some contact sports, car accidents, slips and falls in the wintertime, something that has altered the normal dynamics of the function of the spine joint-wise, and also the ability now of the spine to lose its normal spinal alignment integrity that again now creates a shifting, or what we call a translation load. And that if that started when you were younger, and as you grow, and the analogy is as the twig is bent, so grows the tree.
Yep.
So if it starts younger and you grow with that, and then all of a sudden you do something that you would normally do when you're 33 years old and bend over and pick up a bar of soap or something, all of a sudden, oh, my back went out. And so you realize that the problem just started then, but really the underlying structural problem has began years ago, but you just weren't aware of it.
Yeah. So if we look at this picture here, you see there's a disc bulge injury. It's very possible that could have been there for a while, that loss of disc integrity, that loss of disc structure, right?
That's correct.
And then the symptoms don't appear for either months or years later.
Well, we know that for a fact because they've done MRI studies on young adults, and they're well aware that I think the numbers are, Walter, help me if we're on, but 40 to 50% of people with disc bulges are really asymptomatic. They don't have any awareness of it at all, but they are present on the MRI.
Yeah, for sure. Very cool. Okay, so now many people they send me their MRI reports by messaging or email. They come to our office, they bring their MRI reports, right? They know what the problem is, but when I ask if a spinal X-ray has been taken, in most cases the answer is no. And if it was from a medical perspective, where and not from a structural analysis perspective, where they're just ruling out fractures, pathologies, things like that, like things that we don't deal with chiropractically. Why is a structural analysis on an X-ray important for disc bulge patients?
Okay, because we need to see, and we take pictures. We typically take those X-rays standing. We want to know what are the loads. What does your blueprint look like when you're standing, or as best that you can stand? We can see where the loads are. Is there a translation load, a lateral bending load, a rotation load, and where is it exactly into the structure? So that's the importance of looking at structure.
Yeah. So here's can you see the X-ray there, Doc?
Yes,
okay.
I can.
Yeah. So this is an X-ray, a standing X-ray of someone's full spine. Now, from the front, the alignment should be straight. Now, there is some shifting here, so ignore that for now. But in the low back, relatively good alignment from the front. I don't have a lateral picture right now, but from the side, so that's from the front, looking at the spine like this. This is a lumbar spine here. From the side, has an elliptical shape curve, okay? So that's the normal ideal spinal model of the lumbar spine. So why is this alignment favorable for discs? Why is it favorable?
Well, the loads are balanced.
Okay.
So the loads are balanced on the joints, the discs, and ligaments, and muscles don't have to be pulled in to create the compensation to that process. So it's really about balancing the loads.
So everything is balanced top to bottom. Okay, now what happens when there's either a shifting like this, or let's say a bending? Let's call it a shift like that. Okay, so let's show up an X-ray now that shows that. Just let me take this down and find it, because I want really people to understand how important is the structural analysis of the spine when they have disc complaints or disc injuries. So let's see here. Okay, let's talk about this one first. So what's happening here? Can you see the picture?
You can see shifting of the spine toward that R, which is the right side of the patient. There's a shifting towards there, and the loads are a lot greater on one side to the other. Okay, so ligaments are being strained, muscles are pulled into action, there's pressure on nerves, and so that's the whole sequelae of looking at the imbalanced structure and the imbalanced stresses and strains it puts on the tissues involved.
Got it. Okay. And so I want people to understand that if you were to come to an office like ours, that we would look at this, okay, and then let me find another picture here for you. And if you guys are enjoying this show so far, please let me know in the comments below. Let me know if you're enjoying this, if you find value in this, and also keep your questions coming. I do see them, and we'll get to them in a moment. So stay on for the live question and answer period. So let me show you an MRI picture. Coming up, 1 second. Here we go. So if someone has only an MRI, okay, let's say they only have an MRI. Do you see it there?
Yes, I see it.
And we don't have the X-ray. Can we really do structural corrective work in terms of restoring alignment and posture? So there's a disc bulge right there.
Yeah.
And it's actually a severe herniation.
Quite large.
Yeah. So can we work with this, or is an X-ray required on top of this?
I would need an X-ray for sure to see where is the abnormal loads.
Yeah.
Because those MRIs are taken lying down. So if someone has a translation or a shift, we may not be able to see it from that. We see that there's an injury, and that's a big herniation.
That's massive.
That's pretty big. So that may not be some, but definitely, either regardless of the degree of the herniation, the bulge, we would still need to see a structural standing upright X-ray to look at the loads that are being present, because that tells us how do we go about and making correction to that.
For sure. Okay, so let's bring in another X-ray here, and let's see here. It's coming up. Okay, let's talk about this one here. What's happening on this one?
So this is an unusual presentation, not too uncommon, but people just don't know they have it. And what we tend to see here is this person has developed what we call a leg length inequality.
So right here.
So we see that the one hip is higher than the other. The level of the sacrum, Walter, you can show where that is.
Right here.
We can see it there. So this, and then we see that the iliac crests are also uneven, as well as there's a shifting of the lower back off to the left of that green marker.
So the green line is the center of where the spine should be, right?
Yes.
And it's a massive shifting occurring here.
Correct.
And on a spinal model, if I had to put down a spinal model, so let's see, right down the center, okay? So it'd be doing something to this effect. It's gonna be hard to do, but it's gonna look different on the screen. Hold on a sec. Something like that, okay? Correct?
Yes.
Okay, it's gonna be hard to do that, but you get the idea. So what's happening to the discs on the model and then correlated to the X-ray?
So we can have a bulging over onto that left-hand side. And because of the structural leg length inequality, which again affects various degrees of the population, I would say at least 10% of the population have some degree of leg length inequality. If we see that on this particular picture, Dr. Walter, we take a specialized picture called a modified Ferguson.
That's right.
Which we can see and measure the actual leg length inequality without the X-ray distortion factor that may be happening with this particular picture. And what we want to do is we need to be able to, again, balance the load. But because there is a leg length inequality, and it's not that the leg length inequality is the sole reason for the disc injury, but it becomes a factor of creating the abnormal loads over time. So part of the process in the care is we want to be able to minimize the strain on the ligaments and the discs and the nerves by addressing the leg length inequality, and we can see how much that addresses in the structure, and then to take care of the rest of the deviation of the spine and the movement factors that happen in the lower back.
Right on. So in reality, it's really hard to stabilize the structure of this if the actual leg length inequality here is not addressed. Is that correct?
Yeah. So that's the other factor where that needs to be looked at. So people look at this, they currently have a problem, they're in pain, they've got numbness, they've lost function, but part of the process in the care in the office to address the underlying problem.
Exactly.
That's what we have to be able to tackle.
And how do you address the leg length inequality?
We use a foot lift.
Okay, now I don't have a foot lift with me, but I have an example of a heel lift. So there's an example of a heel lift.
So those are the old style we used.
Yeah.
I can't quite see it in my view, Walter, but the heel lifts were used years ago. It's all we had. But we ended up finding out that it can put more pressure in the forefoot on the joints. People start complaining of joint issues in the ankle and the forefoot. So now we use a full foot lift. We can either put them inside the shoe. Now there's a limitation because some people have large leg length inequality, say 30 millimeters, 20 millimeters, and you can't put those inside a shoe. Mm-hmm. So we may recommend that you take your shoe to a cob.
Mm-hmm.
Large enough.
Yeah, for sure. Okay, and then let's put this one up here because I know you shared this with me. What's happening here?
So there's the modified Ferguson where the special analysis where we're actually looking at the actual measurement of the leg length inequality. I can't quite see the measurement there, Walter, but we can see that on the left-hand side of the sacrum. Now the sacrum is where the spine sits on top, which is what you're pointing at there. And you can see it's dropped on the left-hand side. So it's dropped on the left-hand side. The spine deviates to the left-hand side. The disc bulges more on the left-hand side. So again, we can treat all we want, but if we're not going to address the strain, the load on the disc because of the leg length problem, we really can't get the spine to become stable.
Mm-hmm. That's right. So people, they really need to understand how much analysis goes. So when we're talking about a disc injury or disc bulge or disc herniation, we can give stretches and exercise. That's right. But there's so much analysis that goes into the corrective process. Would you agree?
Oh,
yes. If everything starts, that's why I tell people, the most important thing is to start with a proper consultation and examination, case review, and spinal analysis, because that dictates not just the diagnosis. And what I mean by diagnosis is not just that there is disc bulge. We can determine that almost clinically, but then we verify it with exams and MRIs. But it verifies also. Gives an idea if it's a left-sided disc bulge, right-sided disc bulge, posterior based on the analysis. And then we need to look at the structural alignment of the spine and correlate that with the clinical symptoms. So the exam is super important, super important. Then we look at the posture, which is the global external picture of the body and how that relates to everything, because sometimes posture doesn't match the spine, and that makes things a bit more complicated. So the exam is super important. So for all of you that are watching, you need to start with a proper structural assessment of the spine and your posture, by a practitioner that is trained in this. And the best, in my opinion,
if I could share an analogy to the viewers, Walter, because they can understand an analogy better.
Absolutely.
Again, I mentioned earlier, if you do look at the structural foundation of a building, if the structure underneath the soil drops, can we see that there? I think you can.
Yeah, bring your hands in closer.
A bit closer.
Yes, there you go. And back up, yeah. It's off the screen. Okay. There you go. You're okay. You're okay.
There. So just think about a structure of a building of a house. If the structure underneath the soil is starting to lower on one side, that itself becomes what we call the number one underlying issue or the primary problem. Mm-hmm. But it also causes secondary problems in the dwelling of the house. Mm-hmm. So the windows are jamming, they don't close properly, the doors are not closing properly, the wall cracks, the floor ends up shifting. Mm-hmm. Those are the secondary components. So for us, we feel pain, we have numbness, we have loss of movement. Those are the secondary conditions of the underlying structural problem.
For sure.
So the focus in our office to look at where is that weakness. Can that weakness become stronger? Can you correct it? And in a lot of those cases, absolutely, or at least a good part of them.
For sure. In terms of a timeline, and now, because we'll talk about the corrective stuff in a moment, how much time realistically, if someone has a disc injury with symptoms, would they take not just to feel good, but also to stabilize the spine? How much time realistically should they expect in that prognosis?
80% of people, Walter, will see changes within 12 weeks to 9 months. That's kind of the reality for most of those cases.
Yeah, and I'm sure that you're gonna attest to the fact that the early changes would be more symptomatology and range of motion and mobility,
Absolutely.
right? And then some of the other
Absolutely.
symptoms like numbness and tingling may take longer to show up, and alignment and posture improvements may take longer to show up. But you're right; it takes anywhere from 3 to 9 months for sure. And that's the reason why we tell patients to stick it through. Like, stay committed, stay on your corrective care plan, follow through with the instructions, the rehab, the exercises, the corrections, because the corrections and the healing takes time. If you look at an injury on a disc, this is something that got injured many years ago, lots of degeneration, and there's a disc bulge there. If this was out of position, out of alignment, that cannot correct in a matter of days or weeks. Realistically, it's not possible. It takes time to stabilize that, for sure. Now, let's talk a little bit about the corrections. What kind of things do you do to correct the spine? Techniques, protocols, and then maybe on another show, we'll show some examples of that. But today, just kind of overview it.
So the main thing has to be able to get that joint play motion back to the individual segments that have
a joint play motion, right?
We use specific chiropractic adjustments. Some people call it manipulation, but it's very specific to the joint play loss that you have. Mm-hmm. So that's number one. You got to get the spine dynamically, mechanically moving where you do not have normal motion. Mm-hmm. Okay, that's number one.
For sure. Number
two, we may show you some active exercises to do, and a lot of you have probably been given those to you by your doctors or physiotherapists, and a lot of the McKenzie protocols or the extension protocols to strengthen the deep back muscles in your core, and that typically comes a little bit later. But some of the passive extensions, like the McKenzie protocol, where you're lying on your stomach, on your forearms, where your lower back is in slight extension. There may be ice that's being applied to reduce the swelling at the same time, which is one protocol that we tend to use in the early phases. So that will be another way. Once you get movement and swelling under control, then we move them into more of a structural improvement process. So if someone has a shift of the spine to the right, we're going to start to move their spine over to the left. And we can use that with corrective adjustments with the way that we set people up, and also some structural corrective exercises. Some people call it sort of traction-based exercise in the mirror image or the opposite of the distortion.
Okay, so that's great. So let's use this as an example. So if we have here, this person has been applied some therapies and corrections, and their symptomatology is improving, their mobility is improving. Now you want to work on the structure. The alignment of the spine in the bad list position is to the right. What would be the protocol for here after we address the leg length? What would be the protocol?
Right. So we would
block,
lie on the left, put a block under the hip area, and also a block under their knees and feet. So those are in the same alignment pattern. Once you lift the left side, the viewers could imagine that the spine, if we lift the left pelvis, that the right side of the spine will drop over to the left-hand side.
Gotcha. And that would be the opposite position. In CBP, it's called the mirror image position traction. And and the idea is we need to overcorrect this structural displacement. You can see it's away from the green line. We need to overcorrect it in the mirror opposite position here, to have it find its neutral position down the center. And we may not get 100% center, and that's okay. But if we can reduce this even by millimeters or percentages, it makes a big difference.
Significantly.
Yeah, for sure. Awesome. Okay, now once things are stabilized structurally, posture is beginning to hold, symptoms are down, a person's functioning better with their quality of life, what kind of functional rehabilitative exercises would you give to someone? Because everyone loves to hear about exercises. And one would, and I'm assuming you're going to say that then now would be a right time to do that, right? Because people get it wrong.
Especially with strength-based exercises, they should only really be done once you have range of motion back, typically. So you add, it's like me having an injury anywhere else. You need to have normal range of motion, active and passive, and joint play before you add strength to the muscles that sit on top of that spinal column. So there's lots you could do. There's core exercises, and I'm sure people have looked online. There's the bird dog, all kinds of things you could do to add some degree of strength around the lower back and core muscles in that area. But that's to be done.
Hold on one second.
Much less pain, and that your posture is starting to improve back to normal.
When it's, yeah, for sure. So when things are stabilizing, and then when they're tolerable, absolutely. Now, the last thing I want to ask before we get into the question and answer period, and for all the viewers out there that are watching, thank you for being on this live interview. And let me know, let us know if you're enjoying this, if you're finding value in this, where you're from, and then keep your questions coming, because we'll go through a live question and answer period. For those of you that are on live, we're going to get to your question on live in just a moment. But once someone's gone through the analysis, the initial symptom relief care and getting them back functioning and moving, the structural care, and then the giving their home exercises for stability and core, how important is to keep up some regimen of supportive care down the road? How important is that, and why?
Well, it's no different, Walter, than people brushing their teeth regularly, because let's face it, life doesn't stop because your body is now healing and functioning better. You have the dynamics of living, whether you're you sit at a desk for your career, you work for the city, and you work collecting garbage, whatever it is for people, or even the chiropractor who is bending over spines for their career, helping other people. The dynamics and stresses and strains on the spine are daily.
Sure.
So there will be a degree of supportive care that we recommend for people who are into really optimizing and making sure that their spine stays that way, as well as coupling that with some of the home-based exercise that we give them.
Awesome. Right on, right on. Okay, so if you guys enjoyed this, let us know. Okay, say yes, I enjoyed this in the chat box. Doc, you ready for some question and answers from our audience?
We're ready. We're ready.
Right on. Now, I'm going to see if I can put them up on the screen so you can see them as well. So let me go back to the beginning. So we'll be on for another 15 or 20 minutes. We'll see how long this takes us, but keep your questions coming. And if we don't address it in the live interview show, put them in the comment section below the video once it posts on YouTube. Also, if you're finding value in this, let us know. If you like this type of content and interview style of video, let me know as well, so I can do more with other docs like Dr. Khalid. And as well, there are tons of people either in your life or family or community or around the world that you may know that need to hear this information and don't have access to this type of information. Share this with them. Share it on your Facebook page, on your Twitter, on your WhatsApp. Email people. Just share people this information, because we want to direct people towards the right proper care when it comes to your spine. And if you need someone, and if you need to find a corrective care chiropractor in your area, we'll do our best to refer you to someone, more likely someone in Canada or United States, and some areas of the world we could possibly help with that as well. So I want to just kind of put that in there. So let me go from the top here. And we have, let's see. Okay, so this is kind of a broad question. So I just want to put up here. Bing asks, is there a remedy for injured disc?
Well, we've been talking about that.
Yeah.
And for 80 to 90% of them, there are. But some of you are maybe whatever you're using, if you're only doing exercises that your physio or medical doctor gave you, it may not solve it for you. And so if you've been battling this for months and you have no success, then it's time to think of another way. And the information that we shared earlier is maybe you have a structural problem that needs a different application. That's
right. And this is a similar question. These are questions that came on at the very early time of the show. So we did that one already here. Eric says, if you have an L405 disc bulge, how can it be treated? First of all, which is the most common? Is it L405 the most common disc bulge area or disc injury area? Is that right? L405 is the most common?
And you know what, Walter, I think they're maybe equal. I'm not sure what you've seen in your practice.
Yeah, exactly. I see them both at the same time, L405 and L5S1. But again, Eric, if you go to the beginning of the show and until to this point here, you'll definitely see how we talked about the treatment protocol and the analysis protocol. Okay, and let's see. Now, in some cases, if someone's asking specific questions of what you should do, we cannot give you that answer specifically to you. This is general information. You should always discuss it with your primary healthcare practitioner. The next steps, we're kind of giving you a guidance of to discuss this with your health practitioner or seek a health practitioner that's trained in this type of work. Okay, so we have Bing. Could this be because of the disc bulge? I was diagnosed in 2012 and felt better after 2 months. Then I'm feeling the back pain again and stiffness and knees down my foot. So that are some general symptoms. And again, it's hard for us to diagnose anything specifically by video, obviously. And can it be related? Maybe, maybe not. And the best way to do is to get an assessment and examination done by a chiropractor in your area, a physio, or a medical doctor that's trained in this type of work. Anything to add there, Doc?
That's about it.
Yeah.
You have to get examined. And again, if people are frustrated with the lack of success, if the application of the treatment is not effective, then we have to think outside, say, well, didn't work for me. I can't just do the exercises. Maybe there is a structural problem that has to be addressed.
Exactly. And that's, again, here's another question by Mazair. Same idea, Mazahir. Sir, I have disc bulge, annular tear, L3, 4, 5, S1. What should I do? Normally, when there's some type of, you have a diagnosis of an annular tear, typically on an MRI, that's an indication that there's been a structural damage that's been existing for some time that needs to be assessed structurally and then corrected structurally. So same idea. Okay, let me go down here. Tony says, yes, enjoying it. Thank you, Tony M. Okay, let's see. This is Luis Carlos. Hi, Dr. Slubro. Nice to see you online. Thank you for that. And I'm still waiting for your help regarding L405S1 herniated disc bulge and protrusion in the nerve canal. I took 1 epidural injection and still have pain. Luis, the best way that we know to help you is by coming in for an assessment or examination. So we can go through the process of determining what kind of care you require, either in my office in Vaughan, in Ottawa area, Dr. Khalid, or someone in your area or city if you're not cannot access that. But I want to talk about this because epidural injection, it's pretty common that people get epidural injections to relieve the pain, but then the pain comes back. What's going on there?
Well, it's no different. We talked about the structural analogy of the building. So people have the structural problem. But what they're doing is they're adding some lubrication to the window. The secondary effect, they make the window glide better. And that's what typical medications do. And we're not against that, but just realize it may not solve the underlying problem. And so you can't just patch the crack up in the wall and expect the underlying structural problem to be corrected. It never happened.
For sure. For sure. Okay, this is Lakshay, and Lakshay says, sir, I'm having a disc bulge in L405S1, and my right leg nerve is compressing. My lower back, my hips is paining very much. And I know there's not a question there, but I totally understand where Lakshay is coming from. How debilitating are disc bulge injuries when they're really symptomatic? Like how does it affect people's lifestyle?
I've had a disc bulge about 8-9 years ago, and I was at the gym, right? So again, people can have underlying structural problems that don't really get addressed fully, and so they can easily have that, but it can be easily successfully treated if you catch it early enough, and you have to be a bit patient. But I will tell you, not only does it affect you physically, but the emotional ability not to be able to move day to day, not to be able to do things with your family, having to put things off because you can't have normal day-to-day movement functions because of pain. I mean, it affects not your physical body, but your emotional well-being as well.
Yeah, for sure. I've had people cry in my office when I'm doing their report of findings. Yeah. Just simply getting out of bed was troublesome. Sleeping at night, like all these things definitely absolutely affects them big time. That's why we want to help as many people as possible with this. Okay, there's a good question. I love this question by Gregorio, what's the difference between a pinched nerve and a bulging disc? Please and thank you. I'll let you tackle that one. And let me put up a picture here, see if it helps.
A pinched nerve can come actually in other places as well. Like there's another sciatic condition called piriformis syndrome or gluteal syndrome, where the nerve gets trapped in the muscle bellies as opposed to from a disc herniation. So a pinched nerve is a kind of a lay term for the public to understand, because you can visualize what happens. But it doesn't, it gets irritated by inflammation from the injured disc. So the disc bulge creates inflammation, and that puts pressure on the nerve. So the pinched nerve is a catch-all phrase for pressure on nerves that don't feel very well. It can happen anywhere in the body. It can happen in your neck, can happen in your back, it can happen through your. Those are more of a peripheral type of neuropathy or pinched nerve, but the pinched nerve is a lay term, Dr. Walter, that doctors use so that you understand what's happened.
That's right. That's right. And the proper terminology would be nerve compression versus a pinched nerve is what people understand. But when there's a neural compression of that nerve, it can radiate pain in the direction of that nerve. So yeah, that was good. Okay, what do we have here? We have, let's see, Eric again. Sir, I have L405 disc bulge and pain at the lower back and right side of the back. And I know there's not a question there, but did we do that one already? Yeah, we did. No, we did not.
It sounds very familiar.
They all sound similar, but these are typical symptoms of that could relate to disc bulges, and you have that already. The key thing is the diagnosis is not enough. The MRI diagnosis is not enough. You need to do proper corrective protocols and cares to really fix the problem that's causing the symptoms and the damage. Okay, we have here working class. Hi, Doc. I had L405 surgery on April 19. Now my lower right back pain, right side hip pain comes back, and tingling toes. What's best exercise to avoid or prevent back pain? So this is good. I like this. So let's talk about someone that has had back surgery, whether it's discectomy or some kind of laminectomy to relieve pressure in the disc and nerves, but they still have back pain later on. What happens with that?
Yeah, I found people who end up with that kind of surgery, Walter. For the most part, people have tried conservative measures, but a lot of time your leg symptoms reduce significantly, which is fantastic. But then there's still the aberrant mechanics of the spine that never got addressed. Again, the structural problem didn't get addressed, but they actually shaved off a bit of the disc. They opened up the neural canal by removing a part of the bone, the laminectomy. So there's more room and there's less pressure on those areas. But leg symptoms may go away, but back pain may not go away. And they tell you that because they're well aware of what they call the failed back syndrome, which is quite high. But if they try not to move you to surgery unless you absolutely have to, where you've tried everything else and your leg symptoms just do not go away, especially when you have drop foot or things of that nature, or those other more nerve compressions for where you lose your bladder and bowel function. Those are more emergency, but for sure. Leg symptoms improve, but the back pain doesn't because, again, the mechanics were never addressed.
And I want people to understand too that even when the surgery goes right, when the surgery is done right, these symptoms can still reoccur later. So it's not like the surgery did not accomplish what it was meant to accomplish. I think they don't use the failed back terminology anymore because it's not like the surgery failed because it was done right and it accomplished what it needed to accomplish. It's just such a complex scenario that the healing process post-surgery, the amount of damage that was there before, it's just very complex that inflammation and scar tissue can still build up and cause residual symptoms or reappearing new symptoms later on as well. Now, what about this? This is a good question. And I actually have a new video coming out soon on my channel about this, on what exercises to avoid. So what exercises should someone avoid if they have disc bulge that are causing symptoms, or even if they have disc bulges that have that are better?
I would, again, every case is so unique, Walter, but I mean, I would not encourage people to do any weight type training while there is injuries to the back and there's pressure on nerves because they're not ready for it. You're just adding more load onto a spine that's not ready to take on more load. So I definitely tell them to avoid weight training type exercises until they have been more functionally and structurally more stable.
Yeah, perfect. Yeah. Okay, so we have over here, I'm not sure what this question is asking. So my dad, yesterday I was told about a disc bulge. So if there's an actual specific question there, please ask us down in the chat box. Okay, Gregorio from Long Beach. Awesome. Thanks for coming on. And we tackled that one. Some of these questions seem to be similar or repeated. Tony M from Greensboro, North Carolina. Awesome. Thanks for that. Lewis, valuable information. Thanks for that. Awesome. And some of these are copy and pasted. Okay, so here's that X from Kashmir. I'm suffering L405 disc bulge. I'm 18 years old. Are disc bulges common in that age group, Doc?
I would say, again, what I've seen clinically, and I think the research is clear, is that there is more evidence of disc bulges and herniations in the younger group as opposed to our senior group.
Yeah, interesting.
Yes.
Yeah. So when the discs have been dehydrated, desiccation is called, that's less likely to bulge. It's less likely to bulge. Doesn't mean they're not injured, just means it's less likely to bulge. And that's what he's talking about. What to do, that X, is get a checkup and by a chiropractor or therapist of some sort, and get proper structural correction. Determine the scenario for you and get proper structural correction. Okay, some of these are repeated as well. Let me go back to this one here. Okay, so here's someone that says Chandeswar, this desiccation. So there is basically pointing out the MRI findings. This desiccation, L405S1 disc bulge, foramina as well, capacious. I'm not sure what that means, and the marrow change and osteoporosis. So lots of degenerative changes going on there. I'm not sure what the question is, but if you have an MRI finding, it's not enough to stop there. You need to get some type of therapy or care done. Okay, let's see this one here. Yunu. So I have L4, L5 disc bulge issue. After that, pain and tingling in my foot, but nowadays reduced pain and tingling. Still have to go for surgery. Thank you. So not sure what the question is, but we're not sure what the circumstance is. Obviously, your doc will know for sure why you have to go for surgery or not. But if you haven't tried conservative care, what would you say to that, Doc? Should someone at least try conservative care before they go to surgery?
It makes sense to try conservative care way before you move into the surgery realm. Absolutely.
Yeah. And, this is a good question. I get asked this question often. What's the best treatment, surgery or some type of therapy? Well, the truth is we don't know for you. We don't know for you until you get an assessment done. There's no way we can know without a checking, examining, doing a case review. But your doc or therapist should be able to guide you through that. Okay. We got a few more questions, then I'm going to wrap this up here. So, okay, this is a good question. Can disc protrusion, this is Lewis, can disc protrusion in a nerve canal be considered cauda equina?
Cauda equina, by definition, is when you have more of that clinical presentation where you have the inability to control, urination and defecation. You're having a bowel movement. You've just lost control. You can't void. You feel full in your bladder and you think you're finished, but you're still full and you feel you can't control that. So that's where it more comes into play. Protrusion into the nerve canal is a very broad term, but it's more so the clinical presentation with loss of that bowel and bladder control. For
sure. So it'd be a clinical impression or diagnosis, immediate referral to the emergency room, and then the emergency docs there would make that decision of what needs to be done. Okay, there's Gregorio. I was doing my morning stretches and felt a crack in my lower back, which was very relieving. I don't feel any pain on my right side lower back or symptoms going down my leg. Okay, great. Thanks for the comment. I'm not sure what the question is, but stretching, I know stretching and movements does cause normal cavitations, which are those quote unquote cracking noises of the spine. And I'm just glad this is relieving for you. All right, let's see here. Phil77. Hello, Phil77. What's up, guys? Have disc bulge L3, L4, L4, L5, L5S1,
Wow.
which is pretty common to see that in multiple areas. Usually one area is going to be more severe, moderate to severe versus mild. Right-sided disc herniation displacing S1 nerve root, have bad nerve pain, and right leg supposed to get injection but delayed. Okay, so let's talk about that displacing the right S1 nerve root. So we talked about that earlier. What happens when that shows up?
Well, there's a whole inflammatory cascade, right? So the bulge is there, and it's a whole inflammatory process where it's around that nerve root area. So the injection there is to try to give you some immediate relief by targeting the inflammation. Mm-hmm. So again, some people get success with it, some people don't. And so again, because maybe the underlying structure and the strains of the loading that we talked about, that's more the underlying problem. And so I hope it works for you. But again, usually if you do get a bit of relief, it's not maybe long lasting and that your symptoms may come back. So do it for relief purposes, but I still think people need to look at their structure because again, Walter, as we know, it's really an underlying cause for 80% of the population.
For sure. And I can't tell you how many times I've had people tell me they've had 1 or 2 or 3 injections in their spine or their lower back, but they still have the same clinical problem and symptoms. So it may provide a symptomatic relief, like Dr. Kelly said, but it's not the answer to correcting the structural problem. Yes. Okay, this is Taylor Bishop. It has been 1 year and 3 months since having slipped disc in L405, and I've been swimming as directed by my GP. Pain is still there, but only when sitting for a few minutes. Should I have surgery? So we cannot answer that question about if you should have surgery. That's not in our scope of practice, and also cannot be determined just by without obviously doing a clinical examination. But let's talk a little bit about the chronicity of this problem. So it's been there for 1 year and 3 months, and it's been giving swimming. How often have you heard people to do swimming for their back complaint or disc problem?
Often, because you are buoyant, right? There's less pressure on your structures when you're floating per se in water, but you can't live there. So even some people, for example, Walter, which I'm curious no one's asked, is the ability of people doing the inversion type therapies for the disc with creating some decompression. That may give you some relief again, but you can't live that way.
Exactly.
You can't live that way. And for a lot of times, even though you're creating this distraction, creating some vacuuming of the spine from the front, but a lot of people, they may have a problem from the side view where they don't have a normal lumbar curve. So people tend to find if they sit too long, it really bothers them. So one simple thing the viewers could do is definitely put something like a rolled up towel in the lower back to keep your lower back in extension, especially if you're having to sit and work at a computer. But again, sitting does bother a lot of people because it does put more pressure on the disc if it's already injured.
Perfect. Okay, and DadX says, thanks, sir. And likewise, I appreciate your questions. Okay, Lewis, along the same line as before, can the caudate equina be present without bladder and bowel loss? There may be signs of saddle anesthesia, which is very serious as well, which is that numbing, tingling sensation, loss of light touch sensation in the saddle area around the rectum area. But usually if those nerves are involved, the bladder and bowel may be involved as well. But if someone came into my office with if they had saddle anesthesia and still were able to control their bowel and bladder, I'll still refer them for an orthopedic or a surgical consultation, because there's no harm in getting a consultation or a set of eyes and an opinion from a surgical professional, and then they'll determine what needs to be done from there. They may send you back to therapy or may go from there. So when those signs begin to show up, then we start to act on them. So it may or may not be the case, but I'd still do a referral for a secondary opinion. What do you think, Doc?
Exactly. That's what I would do exactly.
Yeah. Okay, Bruce. I'm getting treatment for a bulge disc by a chiropractor. Should the doctor avoid that level and only adjust above and below? What a great question, Bruce. Great question. So I'll let you tackle that, Dr. Khalid. So someone has disc bulge. Let's say, let's just shoot L5S1 disc bulge. I'm not sure what it is for Bruce, but let's say it's L5S1. Should the chiropractor avoid that area and adjust only above and below? What do you think?
That's a big question. I'll tell you, the way I decide what segment to adjust is the area of that part of the spine that's not moving properly. So if you feel pain on the right, and it's going in your right leg or buttock, and we go to feel the movement on that side, and it's normal, the joint motion is normal, then we're not going to adjust that side, because the adjustment is designed to restore normal fluid mechanics of the joint, reduce the nervous irritation that goes on to the area, but that is only where a joint has lost that joint play. So it may be on the opposite side. It may be up one level on that side. So yeah, we don't adjust where the pain is. We have to adjust where the dysfunction is.
Yeah, that's right. And in my experience, if someone had an L5S1 disc bulge, I will typically look at the sacrum and adjust the sacrum as indicated, which is below. So the sacrum is right here. Okay. So sacrum, L5, L4. And then if necessary, I can look above as well. So I would go above and below. And as well as Dr. Kelly said, you always want to address the clinical findings of where the structural immobility or lack of ability is. Awesome. Good question there, Bruce. Okay, we have here, and we're going to wrap this up soon. We have Tess Home. Thanks for every information about L405 exercises. I appreciate that. Thank you. And we have Lewis. Carlos, thanks, Doc. You are experts. Appreciate the comment. Dad X, sir, how many years will it take to recover for L405 disc bulge? We addressed this earlier, so I'll just quickly answer. It may not be years, but you can expect, if you're under care, anywhere from 3 months to 9 months, maybe even up to 12 months of continuous corrective style care and supportive care. The whole point is, it took a while to get like that, even though the symptoms may have been immediate. It took a while for the problem to develop. It's going to take some time for it to stabilize and correct. Anything to add there, Doc?
No, that's perfect.
Yeah, perfect. Yeah. Okay, this is cool, and we're not gonna dive into this too much. But Ram says, "Sir, my cervical spine C5, C6 disc bulge is a problem." We'll talk more about the cervical on another video, perhaps. But the same idea applies, whether it's L405 or L5S1 disc bulge. It seems to be a more common clinical diagnosis on MRI findings, in my opinion, from what I've seen in my experience. Back pain is one of the most common, if not the most common reason that brings people to a doctor's office outside the common cold. So that's why it's the most commonly diagnosed situation on MRIs. But the same concept applies, is you want to look at the structural alignment of the neck and the cervical spine, see where it's distorted, and then bring it back to better alignment and reduce the abnormal loads on those discs. So same idea, right?
Exactly.
Awesome. Okay. And Talis says, thank you both. And you're welcome. Appreciate you. And then last one. This is going to be our last question. This is by Ronald. So I had a bulge disc for 5 months. The doctor said it will go in time, but how much longer I feel awful. Will a chiropractor help? I'll let you tackle that to finish off, Dr. Khalid.
Well, I'll tell you, many people suffer as long as you, Ronald, if not maybe even longer. So again, one of the ways that we've helped people get better, and one of the reasons that we've been around since 1895 is because sometimes the main underlying area and also present with a structural type postural problem that can be addressed by a corrective care chiropractor. So you may not need to suffer that long. So again, suffering, I always kind of say pain in life is inevitable, but suffering is optional. But you have to think differently, and you have to be open to a new idea. Mm-hmm. We've been around for a long time, well over 125 years now, for the reason of is that we seem to get a result that no other professions are doing, because we choose to focus on see a person that does corrective care work. I highly recommend for you because it could be a life changer for you.
That's right. Awesome. If you need help finding a corrective care chiropractor in your city, just indicate it in the comments under the video, not the chat box because it disappears after the comments under the video, and we will do our best to refer you to a directory where you can hopefully find someone in your city area. Awesome. And just to wrap it up, Working Class says, thank you for your answer. Love more videos like this, and we'll work on that for sure. And Gregorio, thank you guys. I appreciate you as well. And I want to thank you, first of all of you that came on, our audience this Saturday morning. And we had an awesome amount of people watching. And if you like this type of live show, these type of live interviews with experts, you need to let me know in the comments below, not the chat box, but in the comments, because I'll see them later. And I'll do more of these with other docs if you like this. And also want to thank Dr. Khalid Amanko from Barhaven, Ottawa area in Ontario. And make sure you guys throw some thumbs up in the chat box for him. Thanks, Doc. I really appreciate it.
You're welcome. It was very exciting to be here to share with your audience. That's
pretty cool. And just one last thing, Dr. Khalid and I, we toss cases back and forth to each other, and we rebound ideas. And he's been doing structural corrective care for a long time, and I've learned a lot from him. So I'm really fortunate you came on to this, and I know you probably have lots of value. I think this is the first time I've done an interview on my YouTube channel. I've done it on my Facebook many times, but on my YouTube channel. So I appreciate you for coming on, and I'll talk to you real soon, my friend.
Welcome. Fantastic.
Bye, everyone. Yeah, take care.
Be well, everyone. Bye now.
Bye, everyone. See you, Doc.